All right, well, good evening, everyone. Thanks for coming along to this session of demystifying keratoconus, as we call them. Tonight's topic is corneal crosslinking, and for good reason. Corneal crosslinking today is the primary surgical procedure for keratoconus and is likely to be suggested as a treatment option to almost every patient diagnosed with keratoconus. Patients with progressive keratoconus will be told in most cases that crosslinking is the only treatment available to slow or halt the advance of their condition and the deterioration in their vision. But what is crosslinking? Is there only one way of performing crosslinking? Are all types of crosslinking safe and effective? Who should have crosslinking and who should not? What outcomes can a patient expect from crosslinking? And what are its long-term effects and on vision and the health of the eye? There's so many questions surrounding crosslinking, and patients are not always presented with clear answers or even evidence in support of its safety and effectiveness. To a large extent, that's because there's still not a lot of evidence to support some of the protocols being offered to them by their corneal surgeons. Keratoconus Australia has long been interested in crosslinking because of its potential benefits for people. As some of you might remember, the association supported the world's first randomised trial of crosslinking at the Centre for Eye Research Australia in Melbourne back in 2006. We've also held a series of information forums about crosslinking since then to keep members up to date with the latest results from that study and other research. And we've also had stories from patients who have undergone the procedure. But tonight we're honoured to have Professor Stephanie Watson with us from the Sight Institute in Sydney to explain the various types of crosslinking that have been developed since it was first introduced in Australian practice in about the mid-2000s. Professor Watson will also discuss some of the issues around crosslinking and what we know about this promising procedure, and also what we still don't know. The widespread use of crosslinking over the past decade, without strong evidential backing, can be viewed as problematic. But it's also created an opportunity for researchers to gain information about these crosslinking procedures by finding out what happened to the thousands of patients who've already been crosslinked to date. Professor Watson and her team at SSI saw this opportunity and decided to create a medical registry to track and analyse the results of these operations. Hence the launch in late 2015 of the Australian Keratoconus Registry project, a web-based database and its initial module designed to monitor the outcomes of crosslinking procedures that have been done around Australia and overseas. For the first time, this registry will also include patient quality of life data to analyse how keratoconus patients feel about the results of their operations. Tonight, Professor Watson will discuss this exciting project and explain why it's important to you as patients and also as eye carers. Before I ask Professor Watson to come to the stage, a little about her eminent career. Professor Watson is a corneal and cataract surgeon with appointments at the Sight Institute, the University of Sydney, the Sydney Eye, Prince of Wales, and Sydney Children's Hospitals. She's in practice in Bondi Junction. Professor Watson leads a research program focused on innovative solutions to restore sight and promote eye health. She trains the next generation of eye care workers and researchers. Professor Watson is also recognised internationally for her groundbreaking corneal therapies, including a world-first stem cell transplantation technique. She has over 135 publications and has given over 150 presentations nationally and internationally. Her career has been supported by the National Health and Medical Research Council. As chair of the Ophthalmic Research Institute of Australia, chair Public Health Committee, Royal Australian and New Zealand College of Ophthalmologists, and editor Cochrane Eyes and Vision Group, UK. She contributes to policy development. She was also selected by the University of Sydney for the Chief Executive Women Leaders program, and has completed ARVO Leadership Development Program for Women. Awards that she's received include a first prize on the Medical Device Commercialisation Training Program, Pride of Australia nomination, UNSW Early Stage Innovation Award finalists, Gustav Nossel MHMRC Scholarship, awarded for the highest ranked applicant, and the Less is More Grand Final and People's Choice Award on the New Inventors. So please give Professor Watson a warm welcome. Thank you.
Thank you very much for the invitation to come and speak to you all, and thank you for the kind introduction. So the cornea, as you know, is the window to the soul, but it's also a very important part of our eye that allows us to get clear vision. And keratoconus, unfortunately, affects the cornea in about 1 in 2,000 people. And beginning, as you know, in childhood or as a young adult, it goes on to progressively reduce vision. And the patient then is left with long-term visual issues. But there's a great lack of evidence on the best treatment choices and the outcomes from those treatments. This is a patient with keratoconus that I saw first in 2007, and this is a corneal topography. And most of you are probably familiar with this, but how I like to explain it to the patient is that it's like a geography map of your cornea. And you can see down the bottom here in 2007, the colours, the green and the yellow, are mostly in the same range. But over time, the cornea bulges out and the patient goes on to develop moderate keratoconus. That's the right eye. So now when a patient is having progressive keratoconus, it's now been said that the patient can be cross-linked. So what is cross-linking? Well, basically it's meant to strengthen the corneal stroma. The way I explain it to patients is the cornea is a bit like a sandwich, and it has a number of layers, and those layers are held together by little toothpicks. And when the toothpicks are taken out in keratoconus, the layers slide on each other and the cornea bulges out and changes shape. It's said to make the cross-linking is said to sort of put these little bridges back in the layers to stop them sliding on each other. So that's a cornea with a sloppy sandwich from keratoconus. And so, but you know, that's a very simplified explanation of what happens in cross-linking. There's actually a number of ways that it acts to stabilize the cornea. It's thought to have effects on the keratocytes, which are the cells in the corneal stroma. It also has an effect on the collagen fibers in the cornea, and also on chemical reactions. Now, traditionally it's been done according to what we call the Dresden Protocol. And this protocol involves removing the corneal epithelium, giving riboflavin in dextran for about half an hour, and then using a UV light that goes for about half an hour. But since the introduction of the Dresden Protocol, the developments in cross-linking have come along faster than we've been able to get good evidence as to how they work and what the best protocol to use is. And the reason people have varied these protocols is to try to treat thinner corneas. Because with current protocols, you can't really treat less than 400 micron corneas. And a lot of people with keratoconus, when it's advanced, have thinner corneas than that. Also, taking off the epithelium, you know, is very painful for the patient, and they have a risk of infection. The procedure itself, you know, if you do the full Dresden protocol, takes about an hour, which again is uncomfortable for the patient. And so people have looked at how to make the whole procedure shorter. Then the other variations include combining it with refractive surgery. And this is again is to try to reshape the cornea, or looking at new ways of getting the riboflavin in so it doesn't take half an hour. So that's a little bit about you know, the cross-linking procedure and the basics of it. Now, as I said, we typically want to do cross-linking when the keratoconus is progressing. So it's important to understand a little bit about the natural history of keratoconus, which is generally it stabilises by the patient by the time the patient reaches their 30s. And when it does progress, studies have reported that it does it over a period of about 3 years. And in sort of cross-sectional studies of keratoconus, when you look at a group of keratoconic patients, about between 14 to 40% are found to be progressing. Now, children can have some more severe keratoconus, and they can also progress more rapidly. Now, recently, a global committee was set up to try to determine, well, how do we define when someone actually is progressing? Because if we think the patient needs cross-linking, then we need to know if they're getting worse. And so they came to the conclusion that you needed to have a consistent change in at least 2 parameters that you measure on a patient with keratoconus. And those parameters were basically derived from the topography. And that was including the steepening of the anterior or posterior surface or thinning. They also said that the changes have to be consistent over time and above the noise of the instrument. And that a change in vision actually wasn't required to say if someone was progressing. So how accurate is topography? If our current definitions of progression in keratoconus are based on topography, how much can we rely on the topography to really tell us when a patient is progressing? Well, fortunately, someone has done a study at Moorfields where they looked at the same person repeating the pentacam topography and seeing how much variability there was in the scans. And for a normal patient, you can have about 0.75 diopters of variability. But for someone with advanced keratoconus, that can be up to about 3 to 4 diopters. And so it can be quite difficult to tell if someone is progressing based on topography alone. In early keratoconus, it's about 1 diopter. To get the best measurements as a result of this study, you should really have the same operator using the same equipment to get reliable measurements. And if you're not sure about your measurements, you should repeat them. And then when you're considering whether there's a progression, you need to think about the degree of keratoconus. Now, there's also circumstances in which we can't do cross-linking, and that includes herpes, because that's said to, cross-linking is said to reactivate herpes simplex keratitis. If they've got a history of scarring, infection, neurotrophic corneas or poor wound healing, severe dry eye, pregnancy. Now, patients with keratoconus who get pregnant can progress, but if they are pregnant, we can't actually cross-link them during their pregnancy. IVF may also be another risk factor for progression. So that's sort of the theory about cross-linking and when you might do it. But what about when you're in your clinic and you see these sort of patients with keratoconus? So last week I saw 3 different types of patients, or 3 different people with keratoconus. One was Sally, a young adult. Sally, a young child. Peggy, a young adult, and Don, who was an older adult. And they said to me, "Look, should I have cross-linking?" And so I thought, well, what evidence do I have to be able to tell them whether they should have cross-linking? And a lot of the studies and published data has been done on the Dresden protocol, but protocol variations have come about. And we now have a whole new ways it's being done, and the quality of the evidence is variable as to which is the best method. So, and interestingly, there was recently a large multi-centre clinical trial looking at cross-linking for post-LASIK ectasia. And this included 179 patients, and they had standard cross-linking versus cross-linking with the just no cross-linking, but just putting epithelium on the putting riboflavin on an intact epithelium. Now, the interesting thing from this study is some patients did well, but the patients in the red circle actually got worse. So that's looking at their maximum keratometry and showing that some patients get flattening, but some patients also got steepening. And if you look at the distance vision results, some patients also lost 15 or more letters on the chart, or 5 to 9 letters on the chart. And although the overall data from that study showed that the cross-linking halts the progression of post-LASIK ectasia, there are groups of patients within the study that aren't doing as well, and we need to know why. So, clinical trials have been done of cross-linking, but the clinical trials don't really tell us what's actually happening in the everyday clinic. When you set up a clinical trial, you have very strict criteria that the patient has to meet to go in the trial. They have to be, often a certain age, they have to have a certain amount of keratoconus, they have to have no other diseases. But in the real world, people, and the cross-linking in a clinical trial is done in exactly the same way. But in the real world, people are varying the protocols and the procedures being done on a wider range of people. So to get to the real evidence, I thought, look, we needed to have a registry. So the Safe Sight Registries were set up with the aim of tracking the outcomes of treatments from the real world, so from the real world clinical settings. So every time you see a clinician or a doctor, they have a set of files and they write in those files, and the data from that files pretty much stays in those files. Whereas the registries are designed to enable a practitioner to input their data into the system, and that data that would be otherwise lost and just sitting in the individual practitioner's files is then available for not only that practitioner to review over time, but also for a big collection, the opportunity to get a big collection of data together to answer some of these questions about how patients should be treated in the real world. So it's a web-based system, and it's got various quality assurance measures around it to ensure that we're getting great data. It's an anonymised system, so once the patient's data goes into the system, the practitioner can pull up that patient, but nobody else outside that practitioner can identify that patient's data. It's designed to be quick and easy for clinical practice. So the first visit, you can enter the data in about 30 seconds, and then the follow-up visit takes about 15 seconds. And that's because we're not entering every little bit of data. We want the data that matters, the data that helps the clinician to make a decision, or helps the patient to make a decision in their clinical management. It's an opt-out consent, and so the patients, when they come to the practice, are given a brochure, and if they don't want to partake, they can sign the brochure that they're opting out. Otherwise, they don't have to sign any consent to be part of the process. And the data from the doctor is only identifiable by that doctor. So I don't know who Dr. X, Y, and Z are once the data goes into the registry. The general data is owned by the whole collaboration, but each practitioner can remove their data at any time. And the registries were set up first to track treatment outcomes from neovascular age-related macular degeneration. And this is now the number 1 or 2 prescribed drug on the PBS in terms of cost. And so it's very important to look at people like, and the patient receives the drug by getting an injection into their eye every 2 months. So it's really important. It was really important to know, well, do these treatments actually work, and how often should we give them? And the macular registry now has the largest collection of patient data from this type of treatment in the world. And this is an example of the patient graph from that system, where the vision is tracked with the right eye being red and the right eye being blue and the left eye being red, and the different treatments and activity of the disease shown with the coloured bars across the top. So, the retinal registry looks at a number of conditions, and so after the retinal registry was set up, I thought, look, this would be a really good tool to look at corneal disease. And so I set up the corneal project with keratoconus as the first condition that we were studying. And so this registry is a national registry designed to collect high quality data outcomes to determine the clinical effectiveness and safety of emerging therapies and treatments. And it's we're collecting the data from patients, as I said, in the real life clinical settings, and it's been developed on the back of the macular registry. Now, the data that goes in for each practitioner, they can actually use to benchmark themselves against their peers. The reports can be generated from the system, and the practitioner can have a look and say, well, this is how I'm doing, this is how my patients are doing, and then it shows you how the cohort of other people and other clinicians in the registry are doing. They also get summary reports that include data on how their patients are going in terms of their vision, their treatments that have been given. And these reports meet the requirement for CPD points with the Royal Australian and New Zealand College of Ophthalmologists. So it's an active audit activity. This is an example of the benchmarking reports that are coming out from the Corneal Registry that we've just released. And it's basically showing the mean vision between the patients of the doctor shown and the other doctors in the whole of the registry. And that can basically be generated from the web-based system by the click of a button. It just takes a few seconds. The other thing it generates is this patient graph, similar to the macular registry's graph, which shows the patient journey. And in the clinic, I find this really helpful because you can basically show the patient what's been happening with their keratoconus. The blue line is the right eye vision, and the left eye is red, the left eye vision, and the little diamonds are the K2, so the keratometry, the topography figures. And then up the top you've got little dashes when the patient receives a treatment. And so this patient in this graph here, if you look at the red line, you can see that they were first seen around 2007, and then when they didn't return for follow-up till about 2013, when their vision had decreased and their keratometry had gone up. So this patient had clearly progressed and then went on to have crosslinking, and then their vision and keratometry stabilised afterwards. But as well as knowing about the keratometry, it's important we know about, well, what's happening to the patient with keratoconus? What's happening with their vision? What's happening with their ability to do certain tasks? Can they use a computer? Can they drive? Can they do hobbies? Can they attend to the activities that they need to around the house? Do they feel safe in their environment? Do their eyes get sore from the contact lens wear? Do they get headaches? Is their vision distorted? And so we added to the system, which I've been calling the CORQ, but apparently Konrad Peskov says it's the cork. But it's spelt CORQ, which is a quality of life questionnaire that's been validated for patients with keratoconus. And the patient can fill it out, and it includes all those domains that I was just talking about: driving, day and night, contact lens wear, mobility, computer use, and it tries to get an overall feeling for how the patient is going. Now, that's really important because recently in medicine there's been a lot of interest on patient-reported outcomes, and they've been now being seen as a way of determining the real benefit of treatments to patients. And that's from the point of view of the patients, but also from the point of view of healthcare funders and healthcare agencies, because they don't want to fund treatments that aren't going to deliver a real benefit to the patient. In an orthopaedic centre in Rochester in the United States, they did a study where they gave the patients a questionnaire about their knee, and then they did this is prior to knee replacement surgery, and they measured the patient's knee with a very sophisticated piece of equipment that cost quite a bit of money, and actually the questionnaire achieved the same result, but much quicker and obviously with less resources. So with the registry, we're hoping to get some real data about how patients with keratoconus are doing. And rather than being reliant on topography, we want to also put into the equation the patient's function to determine what treatments they need and which treatments are the best, if they need treatments at all. So how the registry works is when the patient comes to the clinic, they see the orthoptist. The orthoptist generally can identify if they've got keratoconus. The orthoptist will do the vision and do the pentacam, and then they'll put the basic data into the system. The core Q will be completed on an iPad, and that's good. We can increase the font size, and that data goes directly into the system, into the patient's visit. So by the time I've seen the patient, I just finalise the data and the graph is generated. And then I can show the patient their progress, and we can review their quality of life scores, keratometry and vision. And as I said, this it also is an important activity for the clinician in terms of their audit and CPD. And it's an opportunity for them to reflect on their practice, to look at how they're doing compared to their peers, and to make any alterations based on if a certain technique they're doing may not be giving them the results that they want. The data from the macular registry has also created a lot of very high quality research publications. We started putting data into the keratoconus system in 2015. I'll give you an update in a minute about how many eyes and patient data we have in there, but we're just about to start analysing the results to produce publications on what we've found. The macular registry is established around the world. The Netherlands have taken it on across the whole country as their preferred system for audit for macular degeneration. And with the Keratoconus Registry, we have 37 sites around Australia and New Zealand, and we have a site that's just come on board in Rome, and another one in France, one in Austria that's coming on board, and also potentially Switzerland. So the recruitment of this is the macular module has been increasing over time, and with our module, with the keratoconus module, we have over 2,000 eyes from about 1,000 patients. And each time the patient comes, their visit's put on the system. So we have over 11,000 patient visits. And 1,000 of these patients have received cross-linking. So there's quite a bit of data there that over the coming year we'll be generating the reports and analysing what actually the different protocols of cross-linking are, and what effects they've been having on the patients in terms of their vision, their topography, and also their quality of life. The other thing the registry has picked up is adverse events. Now, the current system for notifying adverse events to the TGA involves people reporting the events, and there's been no events as yet reported to the TGA. But we've found that the most common adverse event from the cross-linking procedure has been haze. Some patients have had persistent epithelial defects, infection, scarring, edema, and infiltrates. Now, when you look at the published results of cross-linking for keratoconus, similar to the results for post-LASIK ectasia, there are people that have lost lines of vision, and this is about 3%, and it's more likely to occur if the patient is older and their vision is worse. Now, cross-linking also may not work for everyone. So about 10% of patients are said to still progress despite the cross-linking. And again, this is more common with someone with more advanced keratoconus, with a central cone and a thinner cornea. So what is haze? Well, haze is when you get this opacity in the stroma, and obviously it affects the vision. And it's very common after cross-linking. It's so common that people say, well, the haze is actually a sign that the cross-linking is working. Fortunately for most people, it decreases in the first year. And it extends to a reasonable depth in the corneal stroma. And for some patients, it can go on to cause scarring. And in the literature, rates of corneal scarring have been around 3%. And that scarring can be associated with quite a degree of flattening of the cornea. So in keratoconus, you know, the cornea bulges out and we think, well, flattening might be good, but there's actually some isolated case reports where the cornea has flattened so much it's been very hard to fit contact lenses. Scarring can also occur if the patient gets an infection after the procedure, which unfortunately I've seen happen. So the registry, you know, for the doctor using it, is allowing them to sort of individualise their patient treatment, get an idea of the patient's progress over time, get summaries of how their practice is doing and compare to other doctors, but also importantly contribute to developing national trends and evidence-based guidelines for the cross-linking procedure. So that's the same. And so the benefits to patients is that if the doctor is using the registry, their treatment and their journey can be easily tracked. This can help contribute to best practice and a good understanding of the patient when they're going through the different stages of their keratoconus. As the patient can understand and evaluate the different impacts of the keratoconus on their condition, on themselves. It also allows for referral of the data to another practitioner. So while we await for the results from the registry, I was just going to go through how, at the moment, you know, cross-linking is being dealt with in terms of which patients you see in the clinic and how they should be treated. So this is the young adult that I showed you before, who I saw in the clinic this week. And I showed you her topography at the beginning of the talk, where from 2007 to 2015, she went on to develop more severe keratoconus, and you can see in the refraction that she developed a greater amount of astigmatism. And that was the right eye, which I showed before, from 2007, 2013, 2015. And similarly, in the left eye was worse initially, 2007, 2013, and then 2015. So in a young adult like this, if they've got stable keratoconus and their vision is good in glasses, then they can continue if they're happy with glasses alone. If the keratoconus is stable, they don't necessarily need cross-linking. But if the keratoconus is progressing and they're happy in their glasses, then it's important to consider the cross-linking, because that might keep them in their glasses. And tell the patient to keep their hands off their eyes. So don't rub your eyes. There's the evidence is mainly anecdotal, but there's strong sort of correlations to show that eye rubbing may actually cause the keratoconus to progress, and that in stopping the eye rubbing, it may stop progression and therefore stop the need for having the cross-linking. Now, what about in a young child? Well, I've been referred patients as young as 8, 10, 11, 12, you know, quite young patients with keratoconus. And sometimes they can have very severe keratoconus in one eye and not much keratoconus in the other eye. They can also progress very rapidly. Often by the time I've seen them, they've already progressed to quite an extent. There's even less evidence on what we should do with children and cross-linking keratoconus. There are case series showing that progression can be stopped with the procedure. But there are increased risks of progression following cross-linking in children. And over 5 years, one study reported that about 25% may still progress. They also have a higher risk of infection and scarring. So when you have a young child with keratoconus, it's really a case-by-case decision and involves a careful discussion with the parent. If it's a very mild case and the vision is still very good, you may want to avoid, with few topographic signs, you may want to just monitor the patient. If it's advancing and progressing, consider cross-linking. If it's asymmetric, where one eye is very advanced and the other eye is still 6-6 with minimal or no signs, then I would monitor the good eye. And also they need to get their hands off their eyes too and don't rub them. So what about in an adult? So this is a Don who came to see me, 55, reduced vision, had keratoconus for years, worn glasses since he was a teenager. Used to rub his eyes, but he's stopped now. And that was his vision, 6/12 in each eye, and he was wearing glasses. And this was his topography on the right eye, grade 1 keratoconus according to the pentacam, and grade 2 to 3 on the left. So what do we do about him? Well, he's 55, so thinking about the natural history of keratoconus, it's really very unlikely that he's going to progress. So if he's stable and he's wearing glasses, he should just continue in glasses, or he could try contact lenses if he wanted. If it's progressive, and now these adults that progress at that age, often it can be pellucid marginal degeneration rather than keratoconus, or because they're rubbing their eyes. So then you could consider cross-linking, but it's unusual to need to cross-link someone of that age unless they are progressing, and they also need to get their hands off their eyes. So in summary, with cross-linking, it's still the only currently available treatment able to stop progression in keratoconus. The methods are still evolving. There's new indications, and we need to keep monitoring the outcomes. We want our corneas to look more like this sandwich than the sloppy one I showed you at the beginning. The registry is supported by a team of managers and statisticians and researchers, and they all contribute to making the project what it is. And if you'd like any more information, please feel free to contact us. I'd also like to acknowledge the support from Keratoconus Australia, the Ophthalmic Research Institute of Australia, and the Coffey Foundation, and all the clinicians on the steering committee. Also, we have a patient and stakeholder steering committee. Been grateful to Larry Kornhauser for being part of that committee and helping us try to find better solutions for patients with keratoconus. Thank you. So if anyone has any questions, I'd be happy to, yeah.
I've been told by my specialist that cross-linking will actually, maybe in November, they will know for sure in November, that it will be subsidised by Medicare. Do you know if this is true?
Yeah, there's been an application that's been going through MSAC, which is a government committee that looks at whether there's rebates for item numbers, and it's been under review, and we're waiting for them to make an announcement. Yeah. But you can't ever say what the government's going to say before they do it, because it can all change. But we believe it might be positive. Yeah. Yeah.
Probably if you treat an eye that's under 400 microns,
well, you basically knock off the endothelium. So the cornea has a layer of endothelial cells on the bottom, and what those cells do is keep the fluid out of the cornea. And so if you do a too thin cornea, the UV light affects the endothelium and it damages it. So people have used water to swell the cornea to make it thicker, to keep the light away from the endothelium. So there are various techniques that you can use to sort of treat slightly thinner corneas. People have also tried putting contact lenses on the cornea to create a bit of a spacer.
What changes have you made to the Dresden protocol to make it quicker process?
The main thing that's been done is the shortening of the UV light period, and that's gone by increasing the energy. So it's basically you can do the UV light in 10 minutes if you use a machine that has a high energy output than the original Dresden protocol. Some preliminary data that we looked at from the registry looks like the short and the long version with the UV light has the same outcomes. Oh, sorry, yeah.
With assessing the outcomes, is there any consideration for patients' mental health with regard to the keratoconus?
Yeah, so in the questionnaire, it does sort of go through and ask how you're feeling about the keratoconus and whether it affects your, whether it affects how you're feeling about the way to do various activities. We don't take a mental health history, but part of the core Q assessment is to look at sort of how the patient is feeling and coping with their vision. Yeah.
Is there any evidence for repeat crosslinking for patients that continue to progress?
Yeah, so that's something, it has been reported in the literature that people, are repeating the crosslinking procedure, but there's no sort of large clinical trials. It's mainly just case studies. So particularly if the crosslinking had been the first time done with epithelium on, then it'd be more than reasonable to repeat it with epithelium off. Because if you do epithelium on with standard riboflavin, the evidence is it doesn't work as well. So you could look at it that way. One way of saying, well, yes, that does sort of make sense, because if they've not had a procedure that may have had less effect initially, then you could do the epithelium off, and yeah, that would be, yeah.
Is there any evidence though on the outcome? Because Elsie Chan was telling us some time ago that she thought repeat ones would, the first one could harden the outer layer and make the repeat one less effective, regardless of the
Yeah, look, the evidence is really, really very low quality. Nobody knows, but people have done it. So, to my mind, yes, we need to know, what actually is happening when because it's meant to make, when you do a crosslink, it's meant to make the cornea, so much stronger, and there's biological and mechanical reactions, and if you double it, what happens then? But so yeah, it's very questionable as to repeating it. But if it's been done in a way initially where it wouldn't have had the effects that a normal cross-linking procedure would have, there might be more weight given to considering repeating it, because the person hasn't had the sort of treatment, the full treatment to begin with.
In the post-laser Ectasia study, the cross-linking, what was the cause of reduced acuity when they had the cross-linking done after the laser?
Oh, it can be irregular astigmatism and scarring.
Both of those.
So sorry?
Both of those?
Both well, not at different patients with different, yeah. Yeah.
So, and when does hazing become scarring?
Well, usually, you'd sort of give 3 months for the hazing to go. If there's still sort of opacity by 3 to 6 months, then you're starting to think it's scarring. If it doesn't, the haze should respond generally to topical steroids or go away with time. The scarring just doesn't respond to steroids and won't go away with time. So definitely by a year, that definitely scarring, but probably 6 months, yeah.
The contraindications for patients who have scarring or small amounts of scarring before that cross-linking, do you think that acts as a seeding point, or the cross-linking exacerbates the scars?
Look, again, there's not a lot of evidence around, that what exactly happens, but when you have a scar, you've got keratocytes that have been active or turned into fibroblasts. So the keratocytes are the stromal cells, and when a cornea becomes scarred, those cells turn into fibroblasts, and they also turn into myofibroblasts capable of contracting, and that's the sort of scarring process. So presumably you've already got altered cells in there that are fibroblasts, and maybe they react in a different way. I mean, when you do PRK, or remove the corneal epithelium, you then get sort of reactions in the keratocytes and the stroma, and so any sort of procedures can activate the keratocytes. So the thinking is possibly where you've already got these fibroblast cells or keratocytes prone to activation, and that might be contributing more to the scar. But I don't know that anyone's looked precisely, at that in a study to find out what exactly is going on. Yeah.
So, if you put cortisone drops in the cornea, can that sort of prevent the cross-linking from happening?
Well, the reaction actually continues on after the procedure. So, I don't think so, because it acts in a number of ways. I mean, it might dampen down some of the free radical response, but yeah. I don't think that's been tried. I mean, after this procedure, we give steroids routinely, you know, to try to modulate the wound healing response, because we don't want too much activation of the keratocytes. So presumably not, because the patient uses steroids post-operatively. No. Yeah.
So I'm asking, with corneal transplant, is that still applicable, this cross-linking, and does, I don't think I've heard you say that it actually improves the sight. Is that, it just strengthens it, it doesn't actually improve sight? Is that?
Well, the idea of cross-linking is to stop the progression of keratoconus, and so rather than being a treatment for keratoconus, it's to stop the progression, and then there's the treatments for keratoconus. So you don't do the cross-linking to improve the vision, you do it to stop the keratoconus progressing. And so for the treatments, we still have contact lenses or glasses, contact lenses, and corneal transplant can be done if they've got very advanced keratoconus. But fortunately, most people, you know, less than 10% of patients with keratoconus end up needing a corneal transplant. So it's a different part of the treatment paradigm.
I've got a corneal transplant. Is cross-linking still applicable?
No. Yeah. No, and there's a study in Denmark where they looked at the national registry or the national data, and they found that the rates of corneal transplantation have gone down since cross-linking's been introduced. And so people think that the fact that people have been cross-linked have stopped people getting worse, and less people now are needing transplants.
Question about haze. So, if a patient has a poor reaction with haze in one eye and then progression in the other eye, what are the chances of developing significant haze?
Look, they don't necessarily have to get haze in the other eye. Like, I've seen patients with haze in one eye and not in the other eye, but probably in the second eye, if you did, you'd bump up the steroids and probably watch them more closely. And the other important bit of post-op instruction is to wear sunglasses when they're outside. There were some early cases following PRK where people had PRK and then went to the snow and got really bad, hazing from all the UV exposure. And so we give more advice around the sort of things you can do to reduce your risk of haze. Yeah, just sunglasses, maybe more steroids, yeah.
How would I get my specialist to record the outcomes?
Oh yeah, to participate in the registry.
Do I have to ask him to do that, or?
Yeah, any specialist can join the registry. Yeah. So you can.
I would have to ask him to join.
Yeah, I mean we have a national, the National Congress is next week, and the National Congress we have a booth and we advertise and let the specialists know. But yeah, you can ask the specialist. Yeah.
Topography scan at two different places, and one place I was told the thickness part of the cornea is 420 micron, and the other place I was told 470 micron.
Yeah.
Same eye. Does it vary that much, machine to machine?
That's a big variability, but one thing with the scans is whether we go back to the so with the scans, there's a quality factor on the scans, and so on this topography, if you look under that circle up there and it says QS and it says OK, that means this is a good quality scan. When I'm doing the public clinic and the registrars are bringing me scans and saying, well, there's big differences, often the scan is of poor quality. So if it's like intermediate quality, you'll get a yellow there. If it's poor quality, you'll get a red, which means that there's missing bits of data, that the patient might have not opened their eye enough, and so you're missing a whole bunch of data from underneath the lid. So the first thing I would look at is, well, what is the quality of the scans? And then also whether they were done on the same type of machines, because some machines are more accurate than other machines. So there's probably some other factors rather than the cornea sort of changing that much. Yeah. Oh, first of all, we check the quality and see see if it was a good scan, and just repeat it, get it repeated. See what quality system it is. But it's difficult because it's more reliable if it's done by the same operator on the same machine. That's the best way to sort of follow your progress.
Would you know if these scans would be rebated by Medicare at all?
Yeah, it's very hard to get stuff rebated. Like again, it's quite a long process, and the reports that have to go in are quite intense, and there's not currently an application in for them to be rebated. Yeah. I know. Yeah, it's the scanning machine. I mean, the scanning machines are sort of 100,000 to 150,000. They're quite expensive machines. But yeah, it's terrible that it doesn't have a rebate. But I think the government's not looking to add more rebates. It's looking to have less rebates. It's important also to remember that the safety net. If you're seeing a number of practitioners or more than one practitioner a number of times in a year, there's this thing called the Medicare safety net that's not widely advertised that you can sign up for, and then you'll get 80% back of anything you pay, including the scans. Then, yeah.
Just on that point, there's a fair bit of concern that costs still increase. We haven't got an answer yet on the rebate.
Yeah.
It is being done free of charge at Sydney Hospital
Yes.
and 2 hospitals in Melbourne,
Yep.
one in Brisbane.
Yeah.
Does that also cover the cost of all these scans?
Yep.
Yeah. So everything's included.
Everything's included. Yeah.
What are the waiting times like these days?
The waiting times, the waiting times. I mean, generally, we try to get it done within sort of about 6 months or so. Yeah, it's
With more urgent cases?
more urgent cases. Yeah, like if you've got a young child that's progressing rapidly, you don't just put them on a list and leave them to wait. Patients. Whereas if it's someone very slow progression, then so the waiting is sort of assigned according to the priority. We don't, we don't make people wait. It's sort of different to cataract surgery, where once you've got the cataract, it doesn't progress that much. Where keratoconus, if it can progress, we'd give them a waiting priority based on their clinical condition. Yeah. And we did an audit recently, and at the eye hospital in our corneal clinics, patients with keratoconus are sort of the majority of patients that are coming through the clinic. And that we have the system up and running there, and it's really saved a lot of time because the files are still all paper and you have to go through everything.
Just one thing that cropped up in the presentation, you said the results were not as good for people over 35. They seem to have more side effects.
Oh, there's more risk of complications? Yeah.
Was that a surprise to you?
Was it more risk of complications? Well, I was just surprised that there were people over 35 having it done as the start.
That would be my next
Yeah.
question. Why are
Yeah.
they doing it even then?
Yeah.
If they're getting worse results as well.
Yeah. Well, hopefully the people are finding that those people are progressing. But there is also a thinking that if someone's got keratoconus, you do cross-linking, whereas it's not really part of the treatment paradigm, it's the part of let's prevent them getting worse, and then you have the treatment sort of treatment arm.
I don't think you mentioned age in your list of issues.
Contraindications?
Well, just how you determine progression or whether they're suitable for cross-linking.
I mean, we still do see people, people over 35, progressing from, so it can't be an absolute contraindication. And so when I initially was talking about keratoconus, I was talking about the natural history, which is it usually doesn't progress after the 30. That's the typical the natural history. So yeah, so the implication of that is if you're not progressing, then you're not needing the cross-linking, and therefore if you're over 30, that's less likely. But we still do see people that progress that are over 30. Often eye rubbing, bad allergy. Sometimes it's pellucid marginal degeneration. So we can't put we can't say don't cross-linking if you're over 35. We just say, look, check for other factors that might be causing them to progress.
guy contacted us last week. He was very upset that his optometrist didn't refer him to Crosslinking. He was 64 and he sort of contacted us wanting to know who else can I see because this guy won't send me for Crosslinking. Like I said, well, 64 is probably more than it is in Crosslinking.
No, well, we think by then they've been naturally cross-linked by the sun, so they probably don't need it. But yeah, I mean, you know, it's important to remember that the procedure does have, I mean, fortunately they're not too high, but there are some adverse events you can get, so it's something that you do want to have an informed discussion with the patient about risk versus benefits and what they're actually doing the cross-linking for and what the outcome that they're hoping to achieve is from the procedure.
Crosslinking has affected for pellucid.
There's even less evidence around pellucid. You know, pellucid's mainly inferior, so some people think that it works, but there's only sort of case series. You'd have to decenter the cross-linking to get to the area where there's the thinning.
Is this an issue with stem cells?
People have done some studies looking at the stem cells with the cross-linking, and they don't think they're particularly affected, but you can always guard the limbus itself, you know, if you're worried. Yeah.
Is there any other application for this treatment, say other collagen thing, maybe tendons or something like that?
Well, people are actually looking at this. I just got back from the European conference in Lisbon, and the Europeans like to do lots of crazy, I did not say that on tape, like to do lots of very interesting, you know, very interesting things, and so they're looking at using it for myopia. To stop, you know, myopia, people get more short-sighted because their eye grows longer. And so people are thinking, well, can we use this to myopia? Can we also, people are looking at it for infections, you know, because it liberates free radicals. Can it kill bugs? And there's a number of large studies around that. Also for bullous keratopathy, where the cornea swells, thinking, well, if we can compact it all together more, it might swell less. So, you know, once you've got a piece of equipment and a treatment, then there are people that look around to see what else you can use it for. Elsewhere in the body, I'm not as certain. Yeah. Yeah. But you know, and people are designing new systems as well. The latest systems they're looking at are ones that treat focal segments of the cornea. So if you've got sort of bad keratoconus in one zone, they're sort of looking at trying to treat just that zone. But you know, that's sort of preliminary, and we really don't know whether that's going to be a good thing, because the keratoconic changes are often through, you know, the whole cornea, and whether if you just treat that zone, whether that's going to be effective in stopping progression, we don't know.
You mentioned that water thickens the cornea. Is it something you can do yourself by washing? Like, is it like, I know that health eye care can be assisted with washing with shampoo.
Oh yeah, that's talking like blepharitis. Yeah, so with blepharitis, but we never put tap water in your eye. Because so the reason it swells because the epithelium's off. You know, normally you've got the epithelium, which is a bit of a barrier, but tap water is actually not clean. It's also not at all like tears, so it's what we call hypertonic, because there's no salt in it. It sucks the salt all out of the tissues into the water, it has, you know, if you look at the Sydney, or here you'd be looking at the Melbourne tap water report from the water people, it actually gives you how many threshold bugs there are, because they allow a certain amount of bugs, you know, in the water that's still fit for human consumption. So and that's one of the causes of an infection we see in contact lens wearers is acanthamoeba, which is thought from washing your lenses in tap water. So it's a protozoan that gets into the contact lenses, and it does a lot of damage to your eye. So the bit about the cleaning the eyes with the water is closing your eyes and putting the warm water on the lids and doing some massage. Yeah.
That's all right, is it? Like,
yeah, that's right, with the eyes closed, and that's if you've got sort of blocked oil glands or dry eye type symptoms. Yeah, you'd close your eyes, apply the heat massage, stroke down, and then stroke up. Yeah.
using?
Using your fingers or a cotton bud. Well, the shampoo is if you've got a lot of crusting, and people used to say use baby shampoo, but you know, if you think about it, we're trying to kind of get a good quality oil, and shampoo sort of breaks away oil. So, so usually you can just use a mixture of bicarbonate of soda. So there's recipes on the internet, but if you put a pint of, you put a teaspoon, I think, in a pint of water and make up the solution, it's a bit less irritant than shampoo. But yeah, but you only there's a lot of people will do the shampoo, whereas the shampoo is for when you've got crusts on the front of the lids. But if you've just got blocked oil glands, you don't necessarily need to do the cleaning bit. You just need to do the massage. Yeah. 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 Yeah.
You were talking about the conference that started your presentation that was discussing the definition of progression.
Yes, yeah.
Have the ophthalmologists sort of reached a consensus now that crosslinking should only be done when progression has been shown by whatever definition, as opposed to this insurance view that a lot of ophthalmologists were taking initially, that everyone should get it done as soon as you've got diagnosed with keratoconus?
I mean, yeah, that's a global consensus paper that was published in a corneal journal. So I mean, people will still have a discussion with patients and say, look, you've got this keratoconus, you're at risk of progressing, you might need cross-linking. So the global Ectasia paper was saying, well, if you want to try to figure out how people are progressing, this is how you can do it. But it wasn't so much saying that if you've got keratoconus, then and talking about cross-linking, it was more about defining what progression is. Yeah. Yeah. That's all right. Yeah.
And generally though, is there still a group of people offering a diagnosis or suggesting a diagnosis, or is there more consensus now around waiting for progression?
I think. Well, I mean, I think. I mean, it's always hard to know precisely what's going on, but I have seen second opinions from people that have come that have been basically diagnosed with keratoconus and said you need cross-linking. Yeah.
Given the poor results from the poorer results for teenagers, is there a view on that, whether you should do it, not do it?
Well, again, there's no evidence-based guidelines because the evidence is slim, and so it's based on people's experience in clinical practice. So there's no what I have in the slide is a viewpoint based on looking at the evidence and what I think is clinically reasonable, but they're not hard and fast guidelines. That's just from the available evidence, and people will practice off their clinical experience. Yep.
Any idea how long it will take to get some more data?
Oh, well, we should be hoping in the coming year. Yeah, well, yeah. It's just that you've got to have a good amount of data, otherwise, it's not doesn't give you the right results. Yeah. And the first part of when the registry went live was sort of getting people onto the system and getting the sort of usage up. So the data really has grown sort of exponentially. So we're hoping, by next year we should have good amounts of data to analyse. Yeah.
What percentage of corneal specialists are contributing data?
Well, we have 37 sites. So that's practice locations across Australia and New Zealand. Nobody knows precisely how many people are doing cross-linking, across Australia and New Zealand, because it's not just, there's some other non-corneal specialists doing cross-linking, but we generally sort of add a couple of centres each month or two, so it is kind of growing. And when we've just released the reports that will allow clinicians to get CPD audits, and that should also further increase the use of the registry. But we believe we have quite good numbers. Questions? Yep. Okay, well, thank you again. Nobody fell asleep. I think that's positive.
Thank you very much for that presentation.
That's
I think
okay.
it was excellent. And I think in regard to the question that was asked over here, it's important that patients also drive the movement of the ophthalmologist towards the registry and ensure that all their corneal surgeons are putting in the
Yeah.
operation. I think it's critical for all of us.
Yeah.
So that's something to think about.
Yeah.
Anyway, thank you very much. There's
Oh,
a
thank
little
you.
gift, and
No,
thank you for
thank
coming
you.
down
No, that's
to
fantastic.
present.
Yeah.
It was really interesting. Thank you.
That's no problem.